Inside the human stomach, a thick, protective biological barrier is all that stands against a highly acidic environment. When that protective mucosal lining fails, the result is peptic ulcer disease, a physical breakdown of the gastrointestinal tissue wall. As seen in this pathogenesis flowchart, pepsin to attack the lining, leading to mucosal erosion. This sequence of biological degradation is what creates every peptic ulcer, regardless of where it forms. But while the biological cause is the same, the specific location where that erosion occurs dictates the patient's symptoms, their daily experience, and the ultimate level of danger. These ulcers typically form in one of two distinct places: the stomach itself, known as a gastric ulcer, or just past the stomach in the upper part of the small intestine, called a duodenal ulcer. Because these anatomical sites are only inches apart, it is common to conflate the symptoms. Misinterpreting the source of the abdominal pain can lead to dangerous delays in proper medical care. To definitively separate the two conditions, we use a diagnostic framework that evaluates the patient profiles, specific pain triggers, and potential complications. Pinpointing the exact location of the ulcer isn't just a technicality, it is the first step in preventing severe, life-threatening outcomes. The diagnostic split begins before the patient even describes their pain. We begin by looking at baseline demographics, their age and body type. This table highlights the gastric ulcer profile. In the age and body type rows, these patients are typically middle-aged, presenting with a thin or weak appearance. Contrast that with the duodenal column, younger adults, typically appearing healthy, overweight, and reporting high stress. While both are more common in males, the difference between an older, undernourished patient and a younger, overweight patient is an important initial indicator. This divergence in physical appearance isn't random. A patient's body weight is a direct, visible consequence of how their specific ulcer reacts to food. The definitive test is the timing of pain relative to eating. One patient physically pushes a plate away, while the other eagerly pulls it closer. For a gastric ulcer, the mechanics are immediate. Food enters the stomach and begins physically irritating the exposed, ulcerated tissue on the stomach wall. The pain response is fast. Because eating causes immediate discomfort, the patient naturally avoids food. This leads to a decreased appetite and explains the clinical weight loss. Duodenal ulcers operate on a delay. Food entering the stomach temporarily buffers the acid, providing relief. It takes an hour and a half to 3 hours for that acidic mass to empty into the intestine and reach the duodenal ulcer. Because eating provides a temporary buffer against the pain, the patient uses food to self-medicate. They eat more frequently to keep the acid at bay, resulting in the characteristic weight gain. Starving oneself versus overeating might look like contradictory behaviors, but they are perfectly logical responses to distinct anatomical pain triggers. This relationship with food also dictates what happens at night when the stomach is entirely empty. Looking at the night pain row, it is common for duodenal ulcers. Without food as a buffer, acid flows into the empty duodenum, causing pain that wakes the patient. Conversely, night pain is rare for gastric ulcers because the resting stomach is empty of irritants. Beyond daily pain, both types of ulcers carry the risk of internal bleeding, but the presentation differs based on the location. This complications chart outlines the difference. Bleeding gastric ulcers typically result in hematemesis, or vomiting blood. Duodenal ulcers, being further down the tract, often present with melena, black tarry stools as the blood is digested. Recognizing whether blood is exiting upwards or downwards allows clinicians to trace the bleeding to its source and intervene before it becomes fatal. The final division between these two ulcers involves their long-term complications. Not all ulcers remain benign. Under cancer risk, gastric ulcers have a significant chance of becoming malignant. Any gastric ulcer over 1 centimeter mandates an immediate biopsy. Malignancy in duodenal ulcers is extremely rare. They may present with kissing ulcers, forming opposite each other, but generally carry no cancer risk. Duodenal ulcers cause immense discomfort, but a gastric ulcer is a ticking clock that must be evaluated for cancer immediately. This summary at the bottom of the page ties together pain, food, and weight. First, the gastric pattern. Food hurts, you don't eat, and you lose weight. Second, the duodenal pattern. Food helps, you eat more, leading to weight gain and night pain. Mastering this behavioral dichotomy empowers patients to read their own bodies and allows medical learners to rapidly identify the correct clinical pathway.